everybody. So today I'll be presenting on a paper by DeRoos and colleagues from 2011 that examined the effectiveness and the efficiency of cognitive behavioral therapy, or CBT, versus eye movement desensitization and reprocessing, EMDR, for trauma-exposed youth. In community samples, over 2/3 of children report having experienced a traumatic incident before the age of 16. Unfortunately, the majority of children who are exposed to trauma do not receive clinical services, even if their symptoms warrant clinical attention. Of those who do receive clinical services, even fewer receive services that are effective and evidence-based. Today, I'll be talking to you about two of the most well-researched interventions for trauma, CBT and EMDR. I'll begin with some background on the protocol and theoretical underpinnings of both of these treatments, and then I'll dive into one of the only 2 randomized control trials that's actually tested these 2 interventions against each other using a child sample. And finally, I'll talk about what conclusions we can get from this research. Cognitive behavioral therapy for trauma begins with psychoeducation, which is essentially learning about trauma, its symptoms, its etiology, and its treatment components. The next part of CBT focuses on recognizing cognitive distortions in the patient's understanding of the traumatic incident and then actively working to restructure these cognitions. The behavioral component of CBT focuses on correcting unhelpful coping behavior, such as emotional blocking or avoidance of certain areas. The next part is the trauma narrative, which is essentially a written account of the traumatic incident by the patient, and it's done in multiple drafts, starting with the facts, to the thoughts and feelings that the patient has about the incident, to a specific focus on the worst moments, and then finally what the patient can conclude from all of this. The patient next engages in vivo exposure to trauma-associated stimuli, and so, for example, if a sexual assault occurred in a bathroom, then the patient would gradually expose him or herself to perhaps the neighborhood where the assault occurred, and then the building, then maybe the floor of the building, and then finally the bathroom itself. So it's gradual. The end of the course of treatment often includes a conjoint parent and caregiver session, and then focuses on safety planning and relapse prevention, which is super important for trauma survivors. One proposed underlying mechanism for CBT is this idea of recognizing these cognitive distortions and actively working to restructure them. So this is often done through the trauma narrative. Common cognitive distortions that trauma survivors, especially little kids, might have is, "What happened was my fault," or "Something terrible could happen at any moment." And after realizing that these are actually distorted cognitions via the trauma narrative, the patient works with the clinician to actively restructure these cognitions into healthier and more realistic understandings, such as these. This trauma narrative, as well as in vivo exposure to the trauma reminders, can also be explained by theories of exposure and habituation. So essentially, when a threatening stimulus occurs, the sympathetic nervous system, or SNS, is activated. The next time that threatening stimulus occurs, you may feel that same heightened level of arousal and distress and anxiety. But it's actually physically impossible for the body to sustain that heightened level of arousal forever. And so, the more and more you are presented to that feared situation, the less and less the anxiety and distress will be. And so, in other words, your body habituates, which is shown here. EMDR similarly begins with psychoeducation and standard rapport building, learning about trauma, and working with a therapist, and that's especially important for little kids. For the bulk of the EMDR treatment, the patient is asked to identify a target memory, which is essentially the memory with the highest level of disturbance within the traumatic incident. With this memory in mind, the patient engages in 30 seconds of desensitization by saccadically moving his or her eyes back and forth, often by following the moving finger of a clinician. So it looks like this. And that continues until the patient no longer feels disturbed by this memory. The patient then embraces a relative positive belief about the event and recognizes and processes any physiological arousal that may still linger. And then finally, the next target memory with the second highest level of disturbance is identified, and then the entire process is repeated. Theoretical explanations for EMDR consider PTSD and post-traumatic stress to be a consequence of failed memory processing. And so essentially, when a traumatic incident occurs, it is stored as an episodic memory in the brain's hippocampus. Typically, episodic memories are converted to semantic memories, which is essentially just just one's general knowledge base. The semantic network is localized in the neocortex. Usually, information from the semantic network is then extracted, and this weakens the feedback and the power of the episodic memory. This process has been shown to occur during REM sleep, or the rapid eye movement stage of sleep. However, it has been proposed that this is actually the process that fails for those with PTSD or elevated trauma symptoms. And so, it is therefore proposed that with these rapid eye movements that I showed you and the redirecting of attention, that EMDR actually induces a neurobiological state similar to that of REM sleep, which allows for the cortical integration of the episodic memory into the semantic network, and thus the reduction in the amygdala-dependent negative affect. So the distress that is often coming along with this episodic traumatic memory. As I mentioned, the objective and purpose of the study that I'm going to be discussing today was to examine the effectiveness and the efficiency of CBT and EMDR, specifically for trauma-exposed youth. Participants included 52 children ages 4 to 18 in the Netherlands, and 47% of the sample identified as ethnic minorities. All of the children had been exposed to a fireworks factory explosion, and they were experiencing elevated post-traumatic stress symptoms as a result. Half of the group was allocated to the CBT condition, and the other to the EMDR condition, and this was a random allocation. Primary outcome measures included parent and child-reported PTSD symptoms, with secondary outcome measures of anxiety symptoms, depression symptoms, and behavioral functioning. And all of these measures were taken at pre, post, and then a 3-month follow-up. Results showed that both CBT and EMDR were quite effective at reducing these PTSD symptoms in these kiddos, with effect sizes of 1.06 all the way up to 1.44. For those of you unfamiliar, an effect size is just a statistic which represents the standardized mean difference between two groups, and above 0.8 is considered large. And so this is really great news. Thumbs up. Importantly, they also found that neither CBT or EMDR was significantly more effective than the other at reducing these PTSD symptoms. Similarly, results showed that both CBT and EMDR were quite effective at reducing all symptoms, meaning not just PTSD, but also the anxiety, depression, and the behavioral functioning problems for all of these kids. And again, neither treatment was shown to be significantly more effective than the other. Interestingly, they also test efficiency, and what they found was that the average kiddo in the CBT group took an average of 4 sessions to become asymptomatic, but it actually only took 3.17 sessions for the average kid in the EMDR condition to become asymptomatic. And so in other words, EMDR might be considered more efficient. There are a number of strengths in this study, including a relatively diverse sample size in terms of ages and ethnicities, as well as 2 active trauma treatment groups instead of a control group or a waitlist control group. They also use randomization, which is considered the gold standard, especially for psychological treatment studies. They also used many validated measures and tested a lot of different symptoms, and they used multiple informants, which means they used symptom reports from both the parent and the child, and that's often really important when you're working with child samples. There are also a couple of limitations that I think are worth mentioning. Most notably that the sample size is relatively small. It was just 52 kids in the Netherlands. Also, they only tested disaster-exposed children, and even though these children had elevated post-traumatic stress symptoms, they still had a relatively low baseline level of trauma compared to some other trauma-exposed youth, and that's something to recognize. The question also arises of whether the statistically significant difference between efficiency results actually translates to clinical significance that providers and patients and clinicians can actually make use of. And finally, because only there was a 3-month follow-up, it's unclear whether these treatment outcome gains can be considered sustainable in the long run. Today, we learned that both CBT and EMDR were quite effective at reducing all symptoms for trauma-exposed youth. Neither treatment was shown to be particularly more effective than the other, although EMDR was considered more effective more efficient, than CBT, meaning it reduced the symptoms in fewer sessions. Overall, the takeaway point I want you to get is that there are a number of children affected by trauma, and there are numerous negative psychological outcomes that may occur from this, and so it is my hope that future research continues to investigate the interventions which can best help these kids, both in the US and worldwide.